Welcome to the Grand Rounds series here at Regenstrief, and we're very pleased to have our own Dr. Nir Menachemi with us from the Fairbanks School of Public Health and the Regenstrief Institute. I'm just going to say a few words about Nir. I know most people know Nir very well. So he's the Fairbanks Endowed Chair and Professor at the Fairbanks School. He is the chair of the Health Policy and Management Department at the Richard M. Fairbanks School of Public Health. And of course, is a scientist with the Regenstrief Institute and internationally recognized in the areas of informatics and healthcare research, organizational science and improvement science, cost effectiveness, et cetera. His research really focuses at the intersection of health policy, medicine, and business. And from the start of the pandemic, he's been working diligently and been the PI on a number of different projects, importantly, the ones he's going to talk to us about today around our SARS-CoV-2 prevalence study that has really been an internationally recognized and widely cited breakthrough paper and series of work that he and the team that he has led have generated to tell us more about what's happening with COVID, not only in Indiana, but to really inform what's happening worldwide. So with that, I will turn it over to Nir for his grand rounds.
Thank you. Appreciate the opportunity to be here and look forward to the questions either through the chat or if you feel so inclined to ask by unmuting yourself. I have obviously remarks that I'll get through, but love the conversation. The more the merrier. And if you want to wait till the end, that's good too, but I'm not necessarily expecting that. So many of you probably know of the Indiana Prevalence Study, which is what the official name is, but Governor Holcomb always refers to it as the Fairbanks Prevalence Study. So I kind of use that in the title. I want to give you guys an update on, number one, where we are today, but also just bring you back up to speed on everything that we accomplished and why we did it and why it was somewhat unique and how it ultimately informed where we are today. So just want to shout out what has been one of the most delightful teams I've ever been on. That's obviously very multidisciplinary, spanning our colleagues both at the School of Medicine and the Fairbanks School, with several important players from the Institute, which made this partnership with the Indiana Department of Health possible, and obviously at the request of the governor, which I'll talk a little bit about in a second. But to kind of wrap your head around what we did and why it was so different, when you think about everything we knew about the pandemic, and you even go back like a year ago when we were just locking down, the uncertainty was unbelievably high, everyone was worried. Almost everything we knew about COVID came from hospitalized patients, mostly from China, then eventually from Italy, and then eventually from New York. But when you think about it, everyone that can be infected is represented here on this pyramid. People at the base of the pyramid might be infected and not even know it because they're not showing any symptoms. Above them are people who are infected and might have mild symptoms, things like sore throat or cough or fever or something that they might be, chalking up to something else. Some proportion of people with symptoms might show up to a medical setting to get, examined. We know a proportion of them are hospitalized and we know a proportion of them die. And so the reason that it's so important to stress the fact that everything we knew about the disease came from people who were in the hospital or at best presenting at the emergency department, it quickly shows you that we didn't know about most of the people who might be infected. Now, related to that, our state, just like every state, and if you followed the Johns Hopkins website since the beginning of the pandemic, keeps reporting about cases. How many new cases do we have? And cases are really important, but to be a case, by definition, you have to test positive. And you can imagine that people at the bottom of the pyramid either don't get tested because they don't know they're infected, or don't get tested because tests aren't prioritized for their use, even if they show up to the clinic. And so cases at the end of the day ends up underestimating infections. And I'm going to use those two terms and wanted to define them. Cases are people who test positive, and infections are everyone that might be currently infected or might be ever infected. So a lot of infections never become cases and then as a result aren't counted. Now, one of the reasons the pandemic is what it is that the vast majority of spread in the community occurs by people who are never identified as cases. This is why it's been so challenging and why it's been so difficult, both from a public health measures perspective and from a policy perspective, is because we don't know what we don't count and what we can't see. And so at the end of the day, what we were trying to do with the Indiana Prevalence Study was trying to understand how many people are infected on the entire pyramid, above and beyond what we were getting from case reports, and more importantly, track how many people in Indiana have ever been infected at any given time point, in part because most policy decisions have to be driven by how many people are infected, not only based on how many cases there are. Obviously, cases are important because they are at higher risk of needing clinical services, and we can very quickly overwhelm the clinical resources that we have in the state or the country or so forth. But needing to know how many people are infected actually gives us much better ability to predict how many people might ultimately be cases and as a result might need hospital or other resources. And so when we got contacted, and this is now, my God, a little bit more than a year ago, it was the end of March, when we were in conversations with the governor's office, when he basically said he wants to know what kind of data he even needs that we're not going to have to be able to drive decision making. And we came back to that larger team that I showed you, and basically said, we need to randomly sample folks from the communities across Indiana to get a sense of how many people are infected. And one of the things that made us a little bit unique is that not only did we randomly sample at the state level and at the scale of the state stratified by each of the preparedness districts of Indiana, but we simultaneously tested everyone that we invited for active viral infection using PCR tests, and also for the presence of antibodies using blood draws. And so we were able to estimate how many people are sick, right, or not sick, infected right now, including people who are asymptomatic, but also be able to determine how many people have evidence of previously been exposed to the virus and may have had previous infections. And you got to put this in the context. We had extremely low testing capacity in the state. Most doctors who wanted to order tests couldn't get it. And most of the tests that were ordered came 5 days later because they routed through whatever labs. And ultimately, you know, by the time the information got back to clinical decision makers, whatever they did had already been done. And so the tests were very scarce, and, you know, exclusively deployed on sick people, so to speak, not necessarily everyone who was infected. And from an informatics perspective, you know, generating a list of everyone in the state was not an easy task. I mean, most people in our world probably know this, but there isn't a list of Hoosiers. I don't think the average citizen realizes it. And so we had to invent a way to get to a list of Hoosiers, figure out a way to get contact information on that list, randomly select off of it, and then outreach those people. And by the way, this had to be done expeditiously for obvious reasons. And so when you think about studies of this scale, I usually have months and months and months to write a proposal. I then may have a year to plan for implementation, then I have a year to implement it. Our team had to do everything from start to finish in like 3 weeks. And it was literally the 3 weeks that correspond to about a year ago. And so to generate that list, we identified people who filed taxes in the state of Indiana with an Indiana address. And if you filed or co-filed a tax or your tax return in Indiana, and everyone that was listed as a dependent on an Indiana tax return with an Indiana address was kind of our universe. And then we combined folks from that list that we randomly selected with contact info from the Bureau of Motor Vehicles, in part because by law, you have 30 days to notify the state of your change in address. And that's where the most reliable information is. But we also got contact info like emails and addresses and phone numbers from any state data source that might have serviced Hoosiers. So if you applied for Medicaid, or you got WIC, or you got any other state benefit or federal benefit administered through the states, we were able to get your information that way. Now, what are we trying to do here? We're trying to determine the number of people currently and ever on that pyramid. So it's not merely the cumulative number of cases, it's the cumulative number of people who have ever been infected. And we were planning to do, and we did, these multiple random samples at different time periods. And another way to think about this is really, what is the denominator of people who have been infected? Up until we did our study, almost all the kind of rates that people were curious about, how many people are dying, or it was all a function of case counts, not infections. And case counts are biased by how many tests are available and both clinical and patient motivation to get tested. And so it is a moving target that over time either gets more or less reliable by all sorts of unknown factors that are influencing who's ordering a test and who wants a test ordered. And so this was going to provide a denominator to allow us to calculate for the first time what proportion of people who are infected die, what proportion of people who are infected need, go to the hospital, what proportion of infected individuals require ICU care. Up until now, it was really all a function of cases. And if we do know how many people have ever been infected, we're basically telling us as we're going along how far we are from herd immunity, right? This is the number of people who've ever been infected and may have some immunological response to the virus. And this was able to tell us, how far we're along. Now, I think to this day, no one knows exactly what the threshold is. I've seen estimates higher than this. I've seen estimates lower than this. Part of the reason we don't know is because we don't have information on a novel virus. Usually the threshold is determined when we see that when we get to a certain level, infections go down. But if you're not familiar with this word, herd immunity, this term, it basically is what happens when enough people are no longer susceptible to becoming infected, such that those that are susceptible are less likely to get it because they have no one to get it from. And the easiest way to think about this is like with the measles shot. If you're a classroom and everyone is immunized against measles, the one kid who isn't immunized has no one from class to get it from. And so that kid is said to have that group is said to have herd immunity, making it less likely for the unimmunized person to get it. So on April 23rd, and my God, it's now almost a year ago, and the date is a little bit important because we announced at the governor's press conference with Dr. Box that this was going to be done. And this was at the end of our 3-week conceptualization, planning, logistics, and execution phase, knowing that we were going to go out into the field the next day or two and begin testing the randomly selected folks who have already been registering for our study at this time. I should also tell you that because this is such a novel virus, even the folks that have been working on this night and day for the last 12 months, 12 and a half months, and the quote unquote experts, we all only have a year of experience with this. And a year of experience with almost anything in life is just not that impressive. And so that's a caveat here that I think I also want to throw in. And that's something for the lay public to really struggle with. Well, how come the experts don't know? Well, we don't know because not enough time and experience has even elapsed. Why don't you know whether or not the vaccine prevents me from transmitting it? Well, because the earliest people on the planet who've gotten the vaccine in the trials have only had it for about 6 months, and we're still looking at these things. And so we immediately, at the time, had to launch a very aggressive media campaign to raise awareness, in part because there was a lot of scams going on. Remember, this was a time of uncertainty. People were trying to scam folks, calling people, getting a text message saying, oh, you've been magically selected to get tested, when it was impossible to get testing anywhere else. Many folks thought it was a scam. So we worked closely with the media to make that happen. And the reason I put on the date is one day later, New York Times came out with some expert from some East Coast university saying, oh, random sampling is what people should be doing. And we were already in the field, already sort of executing this. And we got contacted. I got contacted by Louis Capello from Harvard afterwards, and he was in shock that this was able to be done so quickly. And, you know, we can talk a little bit about why I think Indiana was the right place at the right time to be able to do this in the Q&A section. But then we had to get the information out, right? So everyone who was randomly selected got postcards, text messages, calls, emails, any which way that we had information on them, we notified them. And we had to erect 68 testing locations around the state. We decided it had to be at least in the adjacent county, so that every person who was randomly selected didn't have to go more than one county over to get tested. Here are just some pictures from, you know, our April testing from almost a year ago. What ended up being a critical piece that was very helpful was the governor called in the National Guard, the Indiana National Guard, to assist with logistics, and directed hundreds of state employees to assist with the project, which made all of the logistics even possible in such a short period of time. And you'll see pictures of some folks, you know, some of our military men and women that were called in as part of the response. People were showing up in really like just cars and cars and cars to get tested. The system of getting people swabbed, and then they came out of their cars to get their blood drawn, and, you know, orderly moved through the process was just an amazing amount of ingenuity and just thought that went in with all the different agencies that played a role in this. And I'll show them in just a second. But let me get to the results of what we found in wave one. And it's a year old now, but I want you to see why it's still so important. So I use the iceberg analogy to talk about this. The number of cases that was known to Indiana at the end of April 2020 was 17,000. So that's how many people at the top of the pyramid existed. The number of people that we had identified had ever been infected in Indiana up until that time period was about 187,000, based on extrapolating off of the random sample, which means there were 10 times more people at the bottom of the pyramid than there was at the top of the pyramid. And it was almost like the iceberg was 10 times larger than what was being able to be seen from cases alone. So I kind of put the pyramid back here, and that's roughly where the waterline is. Not even everyone who was medically attended was being tested. And as a result, cases, we had the first inkling of how much they actually underestimated infections. So one of the things that became really of interest was, now that we have a denominator and we know how many Hoosiers had died up until that time period, the next question was, what is the infection fatality ratio, or what is the probability of death? And when we calculated it at first, it was 0.58%. 1 in 171 people who were infected died. And because we did this at such a large scale, we were able to eventually break this out by age group. But one of the things that was going on from a policy perspective was, you know, what should we do with nursing homes, and what about nursing homes? And, you know, I think a lot of people were sort of erroneously concluding that, oh, if this is just affecting people in nursing homes, then I don't need to worry about it. And so we calculated these ratios separately, with and without the nursing home population in the death counts, mainly because we wanted to know what the probability of death was for someone who's infected out in the community. So we backed out roughly half of the state deaths that were occurring from nursing homes. And as a result, got a slightly lower infection fatality ratio because all those high risk people were taken out. And then we calculated it by age. And this is where it started getting interesting. And finally, with some scientific precision on the world stage on what is the probability of death of getting infected. And as you can see, it's relatively low for people under 30, but relatively high, rivaling some serious cancers for people over 65. And this ultimately was at the heart of understanding the true nature of risks. And you could also see here the just rapid increase across the age bands that by now everyone intuits, but this was really, I think, contributions of our study. Now, I want to show you how powerful this is. And I'm going to use October 1st as an example, right? So as of October 1st in our state, you see here in this column the number of deaths in Indiana by age that have cumulatively occurred at that time. So as of April 1st, 11 people under 30 had died who were not in long-term care, not in a nursing home. 1,033 people above 65. So you can see the biggest proportion of deaths were occurring, obviously, in that higher risk, older age group. But because we scientifically determined that denominator and were able to calculate an infection fatality ratio with scientific precision, these 11 deaths under 30 cannot be explained unless 214,000 infections have occurred in order to explain those 11 observed deaths. And whereas cases are not a good measure of infections, deaths are better than cases at understanding infections, not because they're perfect, but because it's easier to capture and we have a better record of it. And so just by multiplying the probability of death by age by the number of decedents cumulatively observed at any time period, you can get the proportion of infections that this approach predicts. And if you know how many infections there are, you can divide that by the population in that age group. So I can divide 214,000 by the number of Hoosiers that are under 30 and tell you what the prevalence is, or in other words, what the cumulative number of people ever infected in that age group. And that's basically what you see here based on those exact numbers. And as a result, it tells us how far we are from herd immunity because it's tracking the number of people who have ever been infected. Now, much to our delight, this meta-analysis started making its way through the archives and eventually got published. And what they did was they critically appraised all the different methods that were used across the globe to try to estimate this infection fatality ratio. Our study was called out as one of the few that did it on a random sample. But let me just give you an example here of how other people did it. Some people did it based on, like the cruise ship. So one of the first IFR estimates came off of the Diamond Princess cruise ship. They tested everyone. They knew how many people died. They were able to calculate, a numerator and a denominator and get an infection fatality ratio. Others did it based on repatriating people out of China back to their home countries and assumed and tested everyone that was coming back to, say, Japan or Korea or somewhere else. They tested all those people. So by testing all those people, they were able to estimate how many of them got infected, how many of them died, and were able to calculate it. And again, not as good as a random sample. But one of the conclusions of this meta-analysis was that 90% of the variation from one calculated IFR to the other is a function of the age of the group being studied. So the IFR in Indiana, you might recall, was 0.58% before we did the nursing home adjustment. So half of 1%. The IFR on the cruise ship was 1%. And what this meta-analysis basically said is the reason the IFR is different because there are older people on the cruise ship. In other words, there is a static age stratified infection fatality ratio that if we know, it will explain 90% of the deaths, at least from this meta-analysis. So that got us thinking. if we have the best age-specific infection fatality ratios, all we need is another random sample to see if we can get what they got in terms of prevalence. And so the country of Spain randomly selected from 35,000 households, 61,000 participants to do a seroprevalence study where they just drew their blood and looked for the presence of antibodies. A little bit after our Indiana study. And in fact, this is probably the only study in the world that was larger in scope than ours. And what they found was that as of mid-May of a year ago, the percentage of the Spain population that had ever been infected was 6.2%. And you can see here the number of estimated infections by age group and the population prevalence that the Polan et al. Study reported in the Lancet. Well, so our team took the Indiana specific probabilities of death by age, went to the publicly available website that the European Union and separately Spain maintains on how many people died in Spain as of the middle of May and what their age were. And we were able to calculate the prevalence using the method that I just showed you that we kind of, been utilizing here in Indiana, and pretty much hit their estimate on the nose. And all the different age groups were within the confidence intervals. So we felt pretty excited coming back going, we can do this at any time period because our approach is generally validated by some of this experimental data. So that's exactly what we've been doing. And so you can see here the wave 1, 2, and 3 is when we were out in the field doing random sampling. By the time we did wave 3, we had already derived that method that I just showed you. So we also validated our approach against our own wave 3, but we felt like we needed external experimental data as well, and that's where Spain came in. And we've then been tracking this every 2 weeks without having to test anyone, but just analyzing deaths that occur in the state by age. And as of a couple of days ago, we've determined we're at around 26%. So the proportion of people ever infected derived from understanding the relationship between deaths and infections was roughly a quarter of the state population. And because we're tracking this by age, we can also do this by age. And so one of the things that should jump out at you here is that the group between 30 and 49 years old has been pulling up the state average for at least the last 6 months. The folks that are much older have usually had the lowest rates. And we have some reason to believe that it's that 30 to 49-year-olds. And think about that as the, core of the working class Hoosiers, right? These are the people who are disproportionately in essential worker jobs. They're the ones most likely to get infected. And then you see sort of this like slight lag of other people getting infected at other age groups. And this began to give us evidence that, it wasn't necessarily the youngest people or the oldest people that were driving a lot of the community-based infections. So what have we determined overall from the prevalence study? Well, you probably heard the CDC saying that roughly 40% of infections are asymptomatic. That came straight out of our study. And so we were pretty proud at generating that, I guess now, fact about the disease. I showed you the April data. We had 10 times more infections than we did cases. And by November, it was about 3 times. And now it's back up, I think, to around 3. In January, it was down to about 2.5. And then it kind of fluctuated. And so it really showed how much cases and infections don't always track together. I already told you about the IFRs, and it also, because we did this by age, we were able to quantify how much deadlier COVID was than influenza, something that I think just put context onto things. Some of the work that Brian Dixon led early on and was recently published identified the symptoms of people at the lower half of the pyramid. Remember, almost everything we knew about symptoms, whether it was from the World Health Organization or from the CDC, came from severely ill people. Knowing that sense of smell and taste was one of the key things, not in everyone, but one of the key high sensitive, high specific symptoms for people at the bottom half of the pyramid was ultimately work that came out of Indiana. We also sort of saw how the hunkering down slowed the community spread. We looked at that a couple of ways, but it was important stuff that I know the governor relied on. And whereas we knew that minority populations were disproportionately represented among cases, hospitalizations, and deaths, our study, I think, was really the first in the United States to also show that minorities were disproportionately with higher infection burdens, again, the lower half of the pyramid. So in the last I guess we're working on this now since the data came in about 11 months. We've published about 5 papers. We have several more in the pipeline that should be accepted or published sometime soon. Importantly, a lot of this work was just, I think, called out on the national and international stage as unique. The Annals of Internal Medicine paper, if you know what the alt metric is, it's the number of times the media or social media tweets or retweets or shows up in Facebook posts or Reddits or in traditional media outlets. It's a metric of how much media attention an article is getting. And within the first week or two, our study quickly jumped up to the 99.98 percentile of attention in media and social media compared to any scientific paper ever published. And so I think that was pretty exciting for the team to just know that it was having an impact on folks and people were looking at it and talking about it. And that just doesn't happen with a lot of the kind of work that we do in informatics or HSR or, it doesn't hit mainstream in the same way that other things do. And then we had the paper in the Proceedings of the National Academy of Sciences. The National Academy of Medicine called out our work as exemplar. And then some of the other papers with now having a denominator similar to the infection fatality ratio, we could do hospitalization, proportions with a much better denominator. We also got national press, local press. I think that was also a really positive thing. Indiana was getting just a lot of positive attention for the work that was happening here. And here is that slew of testing partners that were critically important in, the random sampling. There was probably, we said back of the envelope, over 1,000 people working on this project while it was, in its active phase before we came up with that method to, determine the prevalence without necessarily going out in the field. But what you could see here is governmental organizations, academic organizations, for-profit, not-for-profit. Every corner of the state pretty much was touched with, people that were mobilized to make this happen. And I know the team is so appreciative. I'm in particular just so, I was in awe by how much just expertise and willpower and ability was possible. I remember when we were trying to figure out even the informatics piece of this, it was Easter weekend. It was Saturday night before Easter last year when we were trying to figure out. I remember we were calling Sean Granis going, we need help on probabilistic matching and the BMV and the management performance hub. Like we just need, and people were just coming out of the woodworks to make this happen. And it was just, such an amazing thing to be part of. So let me stop there, see if, there's questions, conversations.
We do have a couple questions. We had the same question from 2 people, and the question was, how accurate do you think the antibody tests are at confirming previous infection? Because some people were diagnosed and then had the antibody test and it came back negative. And I guess they were advised that the pharmacist said that that's happening a lot. Do you think the severity of infection or possibly the time frame between infection and test could impact that accuracy?
So first of all, yes. And let me kind of put more context on this. So this was really a challenging decision, because when we were making this decision on antibody testing, this was before we even understood anything about antibody waning and just the full immunological response and all these different things. There was something like 40 antibody tests on the market with emergency use authorization. What we ended up doing was trying to figure out which one we should use, knowing that, you know, if we choose a bad one or the wrong one, or how they go about testing for it, it may not ultimately give us information that will be helpful. As luck would have it, and this was after talking to experts at IU Health and at Eli Lilly, both from the lab world and from pathology and from immunology, we ended up going with the Abbott antibody test. And it ended up being the best decision we could make, because after we deployed it, it came out that several antibody waning began happening at, I think it was 12 weeks. But because we were so early in the pandemic, in our first wave, antibody waning was unlikely to have occurred at that point, only because the infection, the overall prevalence was so low and not enough time had gone by. Now, is it possible that someone could have been infected in December or January in Indiana and may have waned by, you know, April? That's possible, but I think that count was pretty low. The other thing was, you know, how the imperfection of these antibody tests with the potential to have false positives and false negatives, and they do. And some of the work that we did statistically in that PNAS paper was to account for the imperfections of the tests, something that a couple of other random sample studies at smaller county levels were criticized for not doing. And so our team sort of, I think, built on the science at the time with being able to do that. But what I'll say in addition is this, it is because we did PCR tests and antibody tests, we actually use the antibody tests to guard against false negatives on the active viral tests. And so it is possible to be infected, but not yet, it is possible to have been previously infected, but not come up yet on antibodies. And so, for example, if you're like within a couple of days of infection, an antibody test will not pick up your immune response yet. But because we were simultaneously testing everyone for active viral infection, we felt pretty good that the PCR test was covering us on false negatives on the antibody test. And so that was, I think, another good decision that the team made, that in combination, that was the best that we had. And we were lucky enough to deploy the best that was possible at the time. Does that make sense?
Sean Grant had a question. Are there confidence intervals for prevalence estimates based on deaths?
Yes, there are, and they're basically derived from the lower and upper bound estimates of our IFRs, which were derived from the lower and upper bound estimates of our original denominator prevalence estimates. I just didn't show them.
Another question was, has something changed with regards to death rate by age groups? Given the supposed inoculation rates for the older population first, it seems death rate has not gone down nearly what would have been expected based on that.
Yeah, so we have not been tracking death rates, and let me even just take a step back. Death rate can mean a lot of things. It can mean how many people died who are of a certain age. It can mean how many people died divided by the number of people that there are in a certain age. And it can also mean what I was just showing you, the probability of death given a certain age. Now, all of those things have like epidemiological terms that are very specific, but I think when we talk about those, sometimes we kind of roll them all up into the same word, death rate. And so I don't think the probability of death has changed much, even though the rate of death might have come down. And so it's important that when a question like that comes up, we kind of differentiate between what we mean.
I need to step back to Sean's question real quick. I did not see his follow-up. He wants to know how wide are those intervals when you're talking about the, what is it that he said? The confidence intervals for prevalence estimates. How wide is that?
So on the 2.8%, I think we had a lower bound that was 1 in high change and an upper bound that was somewhere 4 in middle change.
Nir, what I'm getting at, it's hard to give us through chat, is it seems like in among the groups where the death rate is low, it would seem that 1 or 2 deaths either way could dramatically change your prevalence estimates. And it just seems like that's a highly sensitive number to, have a family, with some sort of deadly genetic disease move into your state and 5 children die and your prevalence estimate shoots up. As a result, there's sensitivities to that sort of thing. And I'm just wondering if you've looked at that to understand how sensitive it is. If it's less sensitive to that, I think there's greater confidence in those numbers. I'm just curious if you all have looked at that.
Yeah, so what you're saying is absolutely right? So obviously 1 additional death in the young age group, which is depicted here with this like dotted line over here. I'm colorblind, but I'm guessing it's orange. You could see it's not a smooth line and it frequently plateaus, in part because I guess advantageously, even though 1 death can go in either way, deaths for this age group are extremely rare. And so we are probably off on the true calculation until 20,000 or so infections occur for us to observe that 1 death. And I think what you're describing is depicted here with these like plateaus where they're suddenly flat, where you could see there's a much smoother curve for the older prevalence estimates, in part because, death is less rare in those groups. And so 1 or 2 deaths don't throw it off as much. But yeah, we have thought about that. And I guess we have felt better because we know these are so rare that you don't get that many extras, and you certainly don't get many extras because they're so rare. But what you described certainly could affect the results if, a family of, vulnerable children suddenly moved and 1 or 2 of them died. We would overestimate the prevalence in that age group, yes. Now, since we're on the topic, let me come back over here and say, if it isn't clear to you, we do not achieve herd immunity very easily without vaccinations. And you just think about how many people have died to get us to this point, and we're only about a quarter of the way there. We would have to have somewhere in the neighborhood of 3 times more deaths to get to roughly 75%. And I don't think that anyone can stomach that many more deaths, not in the United States, not in Indiana, not in any community. And so vaccines end up being the way. And the reason you're seeing so much attention on vaccines right now is because it is literally how we get out of this. And vaccines have caveats right now too with the variants, and we're still trying to figure out everything. But the best we have is that's the best option. And if you haven't already gotten vaccinated or are thinking about it, please do so. We're not going to get out of this any other way, as far as I can tell right now.
So Greg Sachs had a question. How might the emergence of variants and the recent apparent shift to greater hospitalizations and even deaths now in younger patients alter your thinking or approach?
Yeah, great question. So yes, some of the variants that we're seeing are more transmittable. And because of that, we might see more infections. And because of that, we might see more hospitalizations and we might see more deaths. But as best as I can tell, and I've been following this pretty closely, what I'm interested in knowing is whether or not any of the variants change the probability of death or hospitalization given infection. And the best that we can tell is the answer is no. That doesn't mean more hospitalizations aren't occurring, but it just means that the chance of being hospitalized given an infection isn't changing, but we're seeing more hospitalizations because it's more transmittable and as a result more infectious. But yeah, this is kind of getting down there in the weeds, and there is no perfect way of knowing, but that meta-analysis that I showed actually included information that also had variants already in circulation. So it looked at IFR calculations across the world and across different geographies and across, you know, an 11-month period. And it didn't change much from 1 month to the next or from one population to the next when you took into consideration age. And so that suggested that the variants are not changing the probability of death, but are changing the probability of infection, which explains more deaths. I hope that makes sense.
Susan Hickman asked, she said, it is my understanding that improvements in treatment protocols have reduced COVID-19 deaths. If so, is it possible these prevalence estimates are actually underestimates?
So I think that's a good point, and it's also been something that we've been tracking. Anecdotally, I've heard that treatment protocols have been averting deaths, but there actually hasn't been much evidence of that, at least not that I have seen, that is convincing. I think treatment protocols have reduced length of stay. Treatment protocols have made it easier on the patients to manage, but I have not seen that it reduces the likelihood of death necessarily. If that work is out there, I'd love to see it, and we can figure out how to incorporate it into the way we're doing these calculations.
There was a question about response rate. What % of the selected people did not show up to take the test in your randomization, and how might that affect your results?
Excellent question. So only about a quarter of the people who were randomly selected participated. And that was something that we were really worried about. We think there's lots of reasons for it that are probably too long to mention here. But you know, there are standard statistical ways of dealing with non-response. And one of the kind of easiest sort of tool in the statistical tool chest is using inverse probability weights. And to do that, you need to know who didn't respond so that you can weight respondents to reflect the people who didn't respond. The problem with using inverse probability weights for us was that we didn't have any demographic information on non-respondents, in part because if you just think about it, that information doesn't exist in tax records and isn't part of BMV or other information. Yeah, maybe ages, but you know, above that, maybe gender in some cases, but you know, certainly not race. And so what we had to do, and this was work that Konstantin Yanutzos led, who's one of our biostatisticians, we had to estimate, because it was a random sample, we had to assume that the random sample was representative of Hoosiers overall by district, and then use a method known as iterative proportional fitting to reverse engineer what inverse probability weights do in order to get those estimates correctly weighted in our prevalence estimates. And it required a lot of simulation time and a lot of bootstrapping and all sorts of, you know, computational things that were above my head to get right. But that's all documented in that Proceedings of the National Academies of Science paper that I shared, if anyone is interested.
I have one more question. I'm going to invite the audience, if anyone has any last minute questions for Nir, to go ahead and type those in the chat for me. The last one I do have right now is from Paul Dexter. He said, would it seem scientifically valid to use Indiana data on infection fatality rates to calculate prevalence in other states, like without them redoing your study? And if so, do they and do you have reason to believe it influences other state policy decisions?
So yes, I think it would be appropriate because do you know how much each of our waves cost the state? I mean, we don't have an estimate, but the back of the envelope is somewhere in the $5 to $8 million range every time we went out into the field. And I think this method, even if it's quick and dirty, even if it's not perfect, is cheap and easy, and certainly is better than nothing, and has reasonable evidence both from Indiana's wave 3 and Spain that validates it. And so we have been working with several other states to do exactly what you just described. We've worked with other state health departments. We've worked with the CDC. We worked with Maryland and the folks at Hopkins. We've worked with the individual from Harvard and several other folks to basically see and adapt this. One of the biggest challenges is that there is no standard way of backing out nursing home deaths. And it's not that they're not important, but we have to think about them as a separate group, because the policies that affects one should not be the ones that are applied to the other, because they're differently vulnerable. And so we have done this. We've done this for the United States overall. Indiana has lagged the population prevalence of the overall country by a couple of percentage points. And, you know, while we're still talking about it, I'll also mention this. You could see, you know, over the April to like the summer period, we had a certain trajectory, like a slope here that you could see was relatively static, that increased significantly in terms of slope in those winter months. And we're finally leveling that off. You're beginning to see the beginning of what we hope is a plateau that might be driven by the vaccines. It might be driven by the springtime weather. It might be driven by any number of things, including people being more regularly adhering to precautions. But, you know, as is everything with the pandemic, you got to take a multitude of data sources and data points to understand what's going on, because no one thing tells you everything you need to know to make decisions. Not as a policymaker, not as a citizen, not as a clinician. And probably, I think where we as an institute shine is we have that expertise all wrapped up in one place. And I think that's why we've been so helpful on multiple fronts of the pandemic, especially as it pertains to understanding data and consuming and understanding what data mean to sort of inform decisions at all those levels. And so it's been kind of cool to be part of an organization that is just pushing the envelope yet again on something that only we can do in the state in the way that we have. And I think we've learned from our colleagues in other states, and we've also done our share of sharing what we have learned to improve their response. And so going back to Paul's question, yes, we have been working very closely with those other states, and not just on these calculations, but on a lot of things going on, which is pretty neat.
Here, I don't see any other questions.
Thank you.
So, Peter,
Hey,
go
Tina,
ahead.
thank you so much for moderating that. You did a fantastic job. We are coming to the end of time, but Nir, just want to thank you again for all of the work and for such a great presentation, and to everybody else for all of your engagement. Really outstanding work, and I know we'll be keeping a close eye on this moving forward, because there's more to be done. So thank you.
Thank you, and appreciate everyone's time.